Hello. Okay. Good morning all. I'll be presenting about an innovative and low-cost approach to non-contact corneal aesthesiometry. So more often than not, we end up seeing such patients in our OPD with neurotrophic keratitis as well as other signs of decreased corneal sensation, even in diabetic patients. So how do we assess these patients? We have various methods. One is cotton wrist test, which has been always there since a very long time, but it is also having its own disadvantages that it is very crude, and sometimes the results may be very variable, and you cannot quantify it. Apart from that, there is another gold standard technique, which is cocked bonnet aesthesiometry, but then again, this is not available everywhere, and it is very costly, and also inherently the nylon fiber of a cocked bonnet aesthesiometer tends to have some structural damage due to humidity variation. So that gave us our purpose to think about a non-contact method for checking corneal sensations. So what we thought was that if we could control the puff of air released from the NCT machine by the means of a barrier, then by regulating the pressure, we can stimulate the pressure-sensitive corneal nerve supply and thus check the corneal sensitivity. So with the same, we proceeded to make develop a simple, portable, non-invasive method of addressing corneal sensation, and to establish a reliable, qualitative method of non-contact corneal aesthesiometry for screening purpose, and to mitigate the drawbacks of traditional cocked bonnet aesthesiometer, like humidity-associated structural change of the cocked bonnet nylon fiber. So the design was initially done on the CAD software by taking measurements of the NCT machine nozzle, and this is how the design looked on the CAD software, and the final product, which fits very well on the NCT machine. And 3D printing was used to print the adapter. When we talk about the barriers were prepared by the nanosciences lab of Amrita Hospital, wherein the filters were prepared by a technique known as electrospinning, and 3 such filters of varying pore size were prepared, grade 1 having the largest pores and grade 3 having the smallest pore size. So now what we have is a nano-engineered filter, a filter adapter assembly, and when we fit it on the NCT machine, it becomes a non-contact corneal aesthesiometer. This is a short video depicting how the machine is set up. So we switch to the maximum setting of IOP, that is 60 in this machine. Then the center of cornea is focused, after which the adapter is applied and it fits very snugly, it does not move and there is no air leakage. And now the NCCA is ready for use. So after shooting the air puff, we ask the patient about the response. Patient is then asked if he or she could appreciate the air puff. The test begins with the use of grade 3 filter, the one with the smallest pore size, that is the highest impedance to airflow, and then gradually the pore size is increased till patient can appreciate the air puff. So we also tested the NCCA as compared to cocked bonnet aesthesiometer and the cotton wrist test, and what we found in our pilot study was that 50 patients who were included in the study, 4 patients, that is 8 eyes, were found to have reduced corneal sensitivity by non-contact corneal aesthesiometry, who also had a lower than normal age-related central corneal sensitivity by cocked bonnet and aesthesiometer, but had a positive blink reflex, that is a normal reflex on a cotton wisp, indicating that the cotton wisp is a very crude method of judging this, and it was correlating with the cocked bonnet aesthesiometer. So newer surgical procedures like corneal neurotization would definitely benefit from a non-contact method of assessment and tracking of post-operative outcomes, because we need to see, so like in this example, the post-operative recovery is good, but the sensation has to be checked somehow, and for that we can definitely use a non-contact method that will be advisable. And an insight into corneal sensitivity is also important in patients suffering from diabetes mellitus to look for progression of neuropathy, because sometimes these patients, the 4 patients that we have seen in our study were diabetic primarily, and in turn track retinopathy, which go hand in hand as established well in literature. This was our attempt to make a non-contact aesthesiometer, which has fared well in our pilot study, and further ongoing attempts at fine-tuning are taking place. These were my references. Thank you.
How do you grade it? You said you have 3 grades established up till now, and so
yes, ma'am. We began with making filter papers of different pore size, and then we tried and tested all the samples that we were able to create, and then subjectively, like for example, I am having a normal corneal sensitivity as per cocked bonnet aesthesiometer, because that is the gold standard. Then I compared my own corneal sensitivity with these grades, and if I could not feel the air puff at grade 1, that would mean that this is the threshold for a normal. So this is a process which we are going through. We are still developing and trying to figure out. Our next step would be to quantify the millibar pressure that is to be perceived by the cornea.
So is it still very subjective? It's the patient's...
Ma'am, even the cockpit bone anesthesiometer, we need to ask the patient if he could feel the tip of the cockpit bone anesthesiometer. So that is also subjective. And this is another just non-invasive method of checking corneal sensation.
And what's the surface area of the air puff?
Ma'am, the nozzle is 1 mm, which has also been done earlier. In 1998, there was a paper by Dr. Murphy, wherein he created a non-contact corneal anesthesiometer. The only thing is that he created a machine. Ours is an adapter which fits well into NCT machine, so it can be used everywhere. And he also took 1 mm of the nozzle size, and the distance between the eye and the nozzle was 1 centimeter, which we have also replicated.
So all 3 grades you changed the
adapters,
the
yes, ma'am. I brought the adapters and filters if you want to have a look.
Right. Any other question?
Actually, it is something very new, and like you said, but the only problem is now that you don't have any standardization.
We are working for it, ma'am.
Because the thing is that, see, I mean, to try and do this, it's very good. But you are testing on yourself, so you don't have a sample size. Like, say, for example, you have OCT in glaucoma.
Yes.
Then they have reached a particular value after a standardization of so many thousands of.
Yes,
so this is something novel which may work in the future, but like she said, we can't judge, or we can't, there is no quantification or...
Yeah, there is no standardization,
right
that is
now,
true.
But
Yes,
it is definitely something novel and something that we can try.
That is why we are trying to fill in the lacunae here.
Yes.
That there is a huge lacunae that we can...
It is something new, and it is something... something which is very good is to try new things and do something different, which is something very good, and to present it.
Yes.
So that's wonderful.
Thank you, ma'am. Thank you so much.